the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
Greetings to everyone. Welcome to yet another session of PhysioTV classroom. I am Dr. Mudita Chavan, and I am an assistant professor at the Kinesiology and Kinesiotherapy department at Sanjiti Institute for Orthopaedics and Rehabilitation. So for today's session, we are going to explore and get a bit more into the details of positive expiratory pressure. So without any further delay, let's get into the topic. So positive expiratory pressure therapy. The objectives for today's session would be, we will be understanding what exactly is positive expiratory pressure therapy. What is the physiological rationale based on which this therapy was devised or developed? The clinical precautions for this therapy. We will be next enumerating the types of PEP therapy, and finally the common devices that are used and what are the mechanics and the working of these devices briefly. So introduction, this therapy was first brought into and developed in the 1970s and 1980s in Denmark, and since then it has developed very well over the time and has been used widely globally. So this therapy was basically devised for airway clearance, for clearance of secretions, and is currently being used in Europe as well as in the States and all over the world, wherever it can be applicable. So what is the essence of PEP therapy? So the patient, in this therapy, the patient is breathing out against a resistance. This resistance can be of two types, which is flow resistance or a threshold limited resistance. This resistance is going to cause a positive back pressure or the positive airway pressure, which is what this therapy is based on. So the devices which utilize this therapy, which consist of a face mask or a mouthpiece, they incorporate a one-way valve. So what this valve does is it allows for unrestricted or in some cases supported inspiration, but the expiration is where the valve causes a restriction or restriction to the airflow, leading to the positive airway pressure. And this device is dependent on each and every patient's and individual's requirement. So what is the rationale or what is the physiological basis on which this therapy was developed? So there are two major physiological rationales based on which this therapy was developed. First is something that you see in inspiration, and the second is something that you see in expiration. So in inspiration, in cases of severe airway obstruction due to retention of secretions in these airways, small airways, in inspiration with the device, there is a airflow that goes past the secretions, or there are collateral channels to these airways which are activated and utilized for this in this therapy. So as you can see in this picture, these are the first picture shows the alveoli and the bronchioles, the connecting bronchioles. On a closer look, we can see that there are these alveoli, and these alveoli are connected to each other, okay, with the help of certain channels. So the channel connecting two alveoli are called as pore of Kohns. A channel which is connecting the bronchiole to a adjacent alveoli, that is called as the channel of Lambert. And finally, a channel which is connecting two bronchioles is called as the channel of Martin, as you can see here. So in PEP therapy, all these collateral channels are utilized for the treatment. So on a much closer look, so let's understand what is the rationale here. So if in case there is a lot of secretion that is getting accumulated here or in this space, so what happens is with PEP therapy, there will be these alternate channels. So in case there is a inspiratory force that is being generated, so with the inspiration, the air is not going to be able to go into this alveolar sac. Instead, the air will flow into the Martin through the channel of Lambert or through Kohns and enter this alveoli and finally enter behind the secretions which would be lying in this alveolar sac. So in inspiration with PEP therapy, you are able to open up the collateral channels and thus get the air behind the secretions. There will be a higher pressure space that will be created behind it. So if there is a higher pressure space which will be created here as compared to the pressure here, there will be a pressure gradient that will be created. The air will flow from higher pressure to the lower pressure, thus assisting the movement of secretions from the distal area, which is here, to the proximal area, which is here. So that will help or aid to move the secretions from the alveolar sac into the airways and outside. That is why helping in proximal movement of the secretions. So this was the first physiological rationale. Let's understand what is the second one, which is occurring in expiration. Okay. So with expiration, what happens is there is a back pressure that is created. So as we can see here, the positive pressure that will be generated because of the resistance, it will encourage airway splinting, that is keeping the airway open and stabilized, and it will also prevent airway collapse. So there is a concept of dynamic airway closure or airway collapse. So what happens is when the subject tries to expire or in a patient with collapsed airways. So when the patient expires, because of the Bernoulli's theorem, because of that, the airways will immediately close up. Okay, so there will still be some air that will be left back in the alveoli, which is what we learn about as air trapping. So with positive airway pressure, with the patency of the airways staying open for a longer period of time, thus the remaining air can be effectively expired out as well. So based on these two main physiological rationale that occur in inspiration and expiration, it is applied, this technique is applied mainly in cases where there is chances of retained secretion, accumulation, and in cases where there are chances of atelectasis. Okay, let's move on. So before starting with any therapy or any treatment, you should always go through the clinical precautions or some contraindications or relative contraindications to that therapy before you prescribe it to your patient. So let's understand what is the clinical precautions that must be taken for a PEP therapy. First is undrained pneumothorax or a drained pneumothorax. Since we are creating the positive back pressure as we just learned, there will be increased barotrauma to the areas and increased air trapping. Next is post-lung lobectomy or lung transplantation, because in these cases there are chances of forming of fistulas, bronchopulmonary fistulas. Next is the hemodynamic instability or severe cardiovascular disease. Next is undrained empyema or lung abscess. Next is active hemoptysis, because the therapy requires removal of secretions. So in cases of active hemoptysis, it would exaggerate the condition. In cases where the patient is not able to tolerate increased work of breathing, sinusitis, ending with facial fractures or surgery, because as we saw, the therapy requires a mask or a mouthpiece. So in cases of any facial fractures, it would be a precautionary measure to be taken to give this therapy. Finally, a middle ear infection, because the positive back pressure that will be created would cause more added pressure to the middle ear, which would be again a contraindication to this therapy. Let's understand what is the PEP therapy system. So in a PEP therapy system, there is a close fitting mask, there is a one-way valve that is involved, and you can see this blue knob, which is the resistor, or which is the area which will be giving the resistance to the expiratory flow. Another way of using this is a mouthpiece. So here in the mouthpiece, we'll have varying holes or varying diameters of holes, which will offer a expiratory resistance to the flow, and it is not going to generate and much difference or no difference in the pressure generated between all the different interfaces of the system. Okay. And in the initial phases of the therapy, a manometer or a pressure measuring device can be used. So this device will be placed parallel to the resistor to check how much resistance is being created. So to monitor whether the resistance is adequate or whether it's falling short or whether it's higher, it is always advised to use a manometer in the initial phases of the therapy. Okay, so let's get into the therapy. So what are the types of positive expiratory pressure therapies? Okay, so they are basically broadly divided into low PEP, a high PEP therapy, or an oscillatory therapy. Okay, oscillatory PEP therapy. So in low PEP therapy, what the patient performs controlled expiration. So in this, the expiration is going to be controlled and against a resistance. And the main thing that is to be followed in this therapy is to maintain a expiratory pressure at the mouth between 10 to 20 centimeters of water. So aiming to keep it between that is 15 centimeters of water. This is the range of resistance that should be generated while using this therapy. Hence, it is always better to use a manometer which will measure the pressure that is being created, and that will offer a monitor to the therapist also to check whether adequate pressure is being created, and also for the patient, because it will give a visual feedback to the patient whether the effort that he is generating is adequate or not. So in this therapy, there is a slight elevated tidal volume inspiration. So the patient inspires slightly higher volume of breathing during inspiration, and while expiration, the subject is going to apply slightly higher or slightly active expiration. So this is what is termed as low PEP therapy. For this therapy, a resistor should be selected such that it gives a stable pressure of 10 to 20 centimeters of water, okay, during the middle expiration. It is able to allow optimal expiratory flow, and finally, it can be replicated with each therapy or each session. Okay. All right. So let's have a look at a video showing a low pep therapy being used with a mouthpiece. So as you can see, she has held a mouthpiece. She's inspiring from around the area of the mouthpiece or through the nose and expiring into the device, which is causing the chamber or the marker to move between the two uh, gradations. Okay, so it is important to maintain the marker between these two gradings so that you are aware that that much pressure is being generated. After every breath, you are supposed to do a forced expiratory technique followed by a coughing technique, okay, which will help in moving out of the secretions. Okay, so this was the technique where a mouthpiece was used. Let's look at another technique where a face mask is being used. So while using the face mask, the inspiration and the expiration remain same. Again, here the marker needs to be between the two gradings so that you are aware that that much amount of pressure is being generated effectively. And you are inspiring into the mask with the help of your hands. Again, follow it up with 2 FETs, that is forced expiratory techniques, and a cuffing technique to end the session. Okay. So as we saw, what would be your instructions for a low pep therapy? So the patient needs to be seated comfortably and moving forward onto a table or any surface in front of them so that they are taking the support of their elbows. Next, in case of using a mask, as we saw, you have to secure it with your hands, okay? Or if you're holding a mouthpiece, you can hold it in your fingers and hold it near your mouth. So, like we saw, the patient or the subject is going to inspire a slightly larger tidal volume. And the main thing that we'll be looking at is the expiration. So, it will be a slightly active expiration into the mask or the mouthpiece for at least 3 seconds. So, here with the manometer, we will be measuring that the pressure stays between 10 to 20 centimeters of water. This breathing cycle can be repeated for 6 to 12 breaths without losing any seal around the mask or around the mouthpiece. Okay. And the number of breaths that can be advised to a patient will always depend on how much secretion is being mobilized, whether the patient is feeling any fatigue or any dyspnea. Based on that is what the number of breaths or number of cycles that can be given to the patient. Always follow the breathing technique with 2 to 3 forced expiratory techniques and end it with a cough so that all the secretions which have moved from the distal or the peripheral airways into the proximal larger airways are ultimately expectorated out. Okay. Again, the frequency or how many times this treatment or therapy needs to be given out in a day or in a week will depend on the patient's symptom and how much sputum volume is being produced. So this therapy is a pretty independent therapy. Once the patient has been taught how it's supposed to do, they can do it independently on their own. It can be combined with other airway clearance techniques like positioning or inhalation. You can give a nebulization session, and the flexibility of this therapy is such that you can give this therapy even to a younger child or a older individual also. So that was our low pep therapy. Now moving on to the high pep therapy. What exactly is different in high pep therapy as compared to low pep therapy? Let's understand that. So here it is quite similar to low pep therapy. The only thing that is different here is that the forced expiratory technique is also performed into the device. Okay, so the tidal volume and the breath sequence that was followed for low PEP therapy would be the same for high PEP therapy, but here the patient performs forced expiratory maneuver into the PEP mask or into the PEP mouthpiece device. Okay, and the pressure that will be generated for this technique must be between 40 to 120 centimeters of water. Now, how do you decide that how much pressure would you suggest for a patient? So that target pressure for this therapy will be calculated based on this spirometry investigations. So although this technique was developed, it is not widely used. It is the low PEP therapy that is commonly used all around the world as compared to the high PEP therapy. So let's understand what is the rationale for developing this therapy. So when you perform a forced maneuver or a forced expiratory technique, as we saw, there are chances of the airway getting collapsed because of the force of the expiratory flow. There are chances that the airways might end up collapsing. So to prevent that dynamic airway collapse that might occur when you are trying to expectorate or move the secretions from the periphery to the central airways is what will be avoided in the hypertherapy. Okay, so the airways will remain splinted, will remain open for a longer period of time, and allowing that will allow the patient to expectorate or expire for a longer period of time. Let's understand what should be the instructions here. So again, the instructions will be same as low PEP therapy. The only alteration would be of that of the forced expiratory technique. When the cycles are done for the forced expiratory therapy or the forced expiratory maneuver, the patient will inspire into the total lung capacity and forcefully expire into the resistance up to the low lung volumes. And with the manometer, you should be able to judge or you should be able to see a pressure formed for up to 25 to 120 centimeters of water. So again, 2 to 3 FETs can be performed into the device, which will be followed again by a cuffing technique to expectorate these sputums. Again, the sequencing and how many times the cycles of breathing must be given will depend on how much sputum is produced, and the therapy can be ended once the frequency of the sputum is reduced. All right, so we are done with low PEP therapy. We are done with high PEP therapy. Let's understand what is oscillating PEP therapy. So here we will also try to include what is bubble PEP. We'll look into that at the end of the session. So let's understand what is the concept of oscillating PEP therapy. So in oscillating PEP therapy, it is a combination of the PEP therapy that we already studied, plus there will be oscillations or high frequency oscillations that will be created in the airways during the expiratory phase of the breathing cycle. So for this resistance, so in this therapy, the resistance is intermittent. It is not continuous resistance to the expiratory flow. Rather, there will be intermittent or interrupted resistance in this device. So how will this interruption be given out? That will be with three ways. First is whether if there is a ball valve, there might be a lever which is giving out the resistance, and finally the collapsible tubing would be that would be a reason for the interruption to the expiratory flow. Because of the interruptions and because of the intermittent resistance, it will also create oscillations in the airways, which will be transmitted all throughout the airways. Okay. So this is a video explaining the same. So when the subject is performing inspiration, the air is going to be flowing to all parts of the airways. Okay. On a closer look, the green matter that you can see is the secretions that have accumulated in the airways. Okay. So with oscillations, you can see the dark blue line. Those will be the oscillations that will be created, and these oscillations will further generate vibrations to the airway walls. So because of the vibrations, it will help in loosening of the sputum, and the secretions and help to remove the secretions much effectively. So, like we saw, the PEP component is again going to encourage the airflow to go behind the secretions, like we saw with the collateral channels. And it is also in these devices, there is also going to be the oscillatory component. So because of the oscillation, it is going to cause vibrations to the airway walls, which will help in displacing or moving out or loosening the secretions from the airway walls. Okay, and these repeated accelerations will also help in moving the secretions from the periphery to the proximal airways into the larger airways. Okay, so what are the two main devices that are widely used? There are many more devices, but we will be looking at the two major devices that are used. First is the flutter and next is the acapella. So let's understand what happens in flutter. Okay, so in flutter, it is a pipe-like device. Okay, it is handheld with a mouthpiece, and on top of the device, there are perforations or there are holes. And at the end of the device, there is a metal ball or a stainless steel ball which is moving in the device. Okay, so it is this ball that is going to move with the expiration, which will cause interruptions to the expiratory flow. And the PEP that will be, or the positive expiratory pressure that will be generated with this device would range from 18 to 35 centimeters of water. Okay, so what is the reason for generating an oscillatory vibration? So this vibration in the airways will help shear or move the secretions that is being attached to the airways into the lumen of the airway. And it will also, because of the oscillations, it will also help in improving or reducing the viscosity or the viscoelasticity of the secretions, making it more mobile and more easier to move into the larger airways. So these oscillations that are produced, they act or they mimic the ciliary movement of the mucociliary tract. And how much oscillations or how many frequency or how many number of oscillations you want to give to your patient will depend on which angle you are using the device. So with a higher device, it will give a different number of oscillations. If you hold it a little down, it will give a different number of oscillations. So what would be the instructions for the device? First is again the same patient position that was followed for the low PEP therapy. So upright seated position, but this device can also be given in other positions like in PD, only until when the oscillations are effectively being produced. So the number of breaths or how many number of breaths, again, just like low PEP and high PEP, would depend on how much secretions is there, how much volume of secretions is present in the airways, and the fatigue and dyspnea levels of the patient, how much the patient is able to tolerate this therapy. Clinical precautions again would be the same. Only thing here would be, because of the oscillations in patients with hyperreactive airways, the patient might have a premature coughing bout or uncontrolled coughing. So here is a video. Let's look at the video of the subject using a flutter device. So as you can see, it is a pipe-like device. So that is the mouthpiece. This is the chamber where the steel ball is, and there are perforations on top of it. So when she expires, you can see the vibrations in the cheek. Okay, so these vibrations travel down into the chest and into the airways, causing the secretions to loosen up and move ahead into the proximal airways. That was the flutter. Let's understand what is acapella. Okay, another OPEP device, that is oscillatory positive expiratory pressure device. So in acapella, it is a flow operated oscillatory device. So there is a plug and there is a magnet which alter or which create the airflow oscillations in that device. So by breathing and reforming the magnetic attraction of the two objects that is going to cause the intermittent occlusion of the air when the subject is expiring. So again, in this device, you can actually alter the frequency or how much resistance is to be given with the dial, and that will help in adjusting the expiratory pressure that is being created and the oscillations. So it helps to broaden out our patient population and can be adjusted to each individual patient's requirements. Okay. So here again, for the instructions, the inspiration, rather the essence of this device is inspiration can occur through your nose or from around the seal of the mouthpiece with, and you can give short inspiratory hold, after which the subject will perform a active expiration into the device. This will be again followed by huffing, that is the forced expiratory technique, and ending it out with cuffing, which will help in expectoration. Okay. So as compared to flutter, a cappella is known to produce more effective oscillations in the low volume. Okay. And the low expiratory flows, which may be due to severe airflow obstruction or airway instability, or in cases of older age or younger age or the size, this therapy can be better utilized as compared to flutter. Again, a cappella can be given in any position. Most of the positions are ideal for a cappella, so it is not a position dependent device. Here is another video which we'll look at of a subject using a cappella. So it is again a pipe-like device with a mouthpiece. The subject will breathe in from around the device or through the nose and expire into the device. So there is a magnetic component, as we saw, which will be moving, attracting and moving, which will cause the oscillation. So as you can see, this is the part, or this is the object which will be offering the intermittent or interruptions to the expiratory flow. Okay. So after that is done, always follow it up with an FET, that is huffing, and end it with a cuff so that you are able to expectorate whatever secretions have come out. Okay. Finally is bubble pep or bottle pep. So as we saw, these are pretty not complex, but these devices are specific devices. And being in a country like ours, not many or not all population would be able to access these devices. So to target such population, we have an easier method or a more convenient method called as the bubble pep or the bottle pep. Let's understand what that is. So in bubble pep or bottle pep, it can be given to younger patients, okay, or even the patients or babies under the age of 4, okay, who, so in if the patient can or the subject is able to perform the low pep devices but are not able to perform active cycle of breathing technique, or AD is pretty much difficult to understand. So in such a population, bubble pep or bottle pep can be used. Then it is another alternative method for a low pressure OPEP therapy, and it is a type of threshold resistor positive expiratory pressure therapy. So once the expiratory pressure is achieved, it will remain constant throughout the diameter of the tube that is being used to expire. It is a pretty simple and improvised device, can be easily structured and easily constructed, and is very cost effective. So can be used in a lot of patients and in various settings. Okay. So what does this device actually consist of? So it consists of a tube or a straw, preferably rubber, okay, and a bottle which would be half filled with water. So the straw is placed into this water bottle or the container of water, and the patient or the subject inhales through their nose, and then they expire into the water, okay, using this straw and the number of breaths. So this will be the inspiratory cycle and the expiratory cycle into the water. And the number of breaths or the number of cycles will again, just like in flutter and a cappella or other devices, it will again depend on how much sputum volume is being produced. Okay. So blowing through this tubing is going to create bubbles, and these bubbles are the ones that are going to cause the oscillatory effect in this device. The height of the water in the bottle, which will provide the threshold resistance to the expiration, and the bubbling effect is what will be giving the oscillatory effect in this device. Okay, so let's see a video of that as well. So as you can see, there is a container which is filled with yellow water. So they have used soapy water here, okay? And a straw is being used to blow into the water. So with the mouthpiece, the subject is blowing into the tubing or the straw that is going to create bubbles in the water. So you can see the bubbles that are coming up. So this is how the bubble therapy or the bottle therapy is used. Moving forward. So this device can easily be given for children because it is a fun way of engaging them. So to make it more fun, detergent can also be added to make more bubbling effect into the device, or coloring can also be added for a visual feedback. Okay. So precautions or the safety measures to be taken with this device would be to always make sure that the device is clean post and pre-usage. Also, the water which was used should be immediately discarded, and following the treatment, and all the equipment and whatever objects that were used for the device should be thoroughly cleaned. And with every treatment session, a freshly filled water should be taken. Okay. So as we saw, it would be very useful not just in children but also in patients who are not able to use the devices or find the other devices to be very complicated. In these, it is pretty simple to administer and it will help to facilitate the secretions clearance. But a contraindication, or rather a precautionary measure, would be in patients who are confused or have some cognitive impairment. It would be advised to not give this therapy since they might end up inhaling or inspiring the water during the inspiratory phase, which would cause or lead to an aspiration. So in conclusion, we looked at what exactly is positive expiratory pressure therapy, why it is used, where it was developed, that is in Denmark in the 1970s and 80s and still being used worldwide. So following that up with what was the physical or physiological rationale for this therapy, that is two major rationales, that is first airway clearance and in cases of atelectasis. Okay. Finally, the precautionary measures. Before we start with any therapy, what should be the precautionary measures that should be looked after when you start with this therapy, and ending it with the types of therapy, that is the low PEP, high PEP, oscillatory PEP. And in oscillatory PEP, we further looked at flutter, a cappella, and bubble PEP. Okay. So I hope we are able to utilize this session in our clinical practice also. Okay. Thank you so much for listening in, and I will see you in another session next time.